bit older talk, but it's still a very relevant topic on cochlear implant electrode insertion trauma. Here are my disclosures. Sorry, we can advance this. And yeah, let's get right into it. So, briefly want to talk about the principles of cochlear implantation, what we need to do as a surgeon essentially to make it happen, relevant anatomy, about some of the histological studies that are, dealing with intercochlear trauma and insertion studies. And then, based on these data, formulate a clinical algorithm essentially for cochlear access. And this shouldn't really take an hour, so should only take 35 or so minutes. So hopefully we have questions, time for questions at the end. So principles of cochlear implantation in general, right? We implant folks who have a moderate to profound sensory hearing loss. Again, change in indications likely imminent in terms of how much residual hearing we take on, specifically with regards to, aided speech discrimination. Again, limited benefits from conventional amplification. Again, this hearing aid trial, unfortunately, sometimes it's a requirement. We deal with our insurance colleagues all the time about this. And then no active middle ear pathology. Of course, we do take on some folks who have, cholesteatomas and other things, but, properly managed middle ear pathology, I would say. And you need to have a cochlear nerve to be present, really. Implications here, of course, if you don't have a nerve, such in absent cochlear nerves or cochlear nerve deficiencies, and some inner malformations such as common cavities, etc., where the neural structures are really not that good. For us as surgeons, the goals are really to open the cochlea, preferably into scala tympani. Again, that depends mostly on us as surgeons. To insert the electrode into scala tympani, that also depends on us, and there are some electrode factors that are relevant here. And then during insertion, to eliminate this collateral trauma. But again, that's during insertion, but also after insertion. And there's some biological factors, well, a lot of biological factors that seem to be at play here. This is actually a patient, one of my last days when I was at the University of North Carolina, and he he was this good old boy, and he came to this post-op visit, and he said, "Doc, I think you did something wrong, and I found this on my pillowcase." But I found it to be cute. But he basically, he got it. What we try to accomplish, right? We try to get that wire into the cochlea, right? So not entirely wrong here, right? But there's some details that really matter. One of those details is really that scala tympani. About 20 years ago, literature emerged that scala tympani is really better than scala vestibuli. Several kind of landmark articles here from the Skinner et al. Article from WashU, and then the Aschendorf article from Europe really confirmed that. A number of articles have subsequently shown that. And from the Finley et al. Article in 2008, we know that if you model this properly, a 40% improvement in some folks is possible by moving, knowing that as a programming audiologist, programming team, and then certainly avoiding electrode contacts into scala vestibuli is really critical. So and again, the Finley article also showed that the number of electrode contacts into scala vestibuli was directly proportional with decrements in performance, right? So really important article, and subsequent articles have again shown very similar findings. And again, this image up here is the radiographs here from one of these articles, where you can see, contour advanced electrode here that's inserted into scala tympani, right? You can see it here on the cross section, that it's lower here on the cochlear cross section here in the basal turn, and then here in the middle turn. Again, the number of and this is scala vestibuli, right? For example, it's higher up, right, where you can see different electrode, properties here for these insertions, right? So the upper bar would obviously then mean better cochlear implant performance on average. Scale of vestibule isn't that great. There's a possible performance drop again, and likely not able to preserve hearing. And if you look at these histological figures, right? The upper one here is a little obscured by this other picture, but it basically shows an electrode that this is the cone from drilling the cochleostomy, right? And back then when this research started, when I started this research, really when I was a resident, we were all taught to basically not use the round window, but drill this blind hole on the promontory, right? So you basically did a facial recess, didn't do as big of a facial recess back then as we are currently performing. And you basically take a 1 diamond or 1.5 diamond and you drill this, you drill straight down until you find a hole, right? The problem is and I'll show that later, if you just drill this blind hole in the promontory, you'll likely end up in scala vestibuli. And we can see here that's down here, scala tympani, right? That's usually how we orient these histologic images, right? Spiral ligament out here, osteospiral lamina, right? Those would be Rosenthal's canals here on the medial wall, the cochlea with spiral ganglion here, right? So, and if we insert an electrode into scala vestibuli primarily, right, we immediately destroy everything, right? Because that's where the organ of Cortius is right there, right? I don't know if you can see my pointer. I can use the laser pointer. So obviously here, right, would be organ of Corti, right, spiral ligament here, and then also spiral lamina. So you basically destroy everything, right? And really, so scala vestibuli not that great. And we also found out, and that's maybe later for this talk, that over insertions of the electrode are also not great, right? So, anyways, that those are all kind of relevant facts that we learned from the literature back then. This will be a nice insertion, right? There's also a contour advanced electrode. We use that rarely these days, but you can see the electrode here, the electrode contact, right? And you see this contour advanced electrode had a stellate in the middle, in the center. So this is the hole, the channel that hosts the stellate, and obviously here scala tympani, right? And then scala vestibuli. You can easily imagine that if you put an electrode, a foreign body basically in here, you destroy rhizomous membrane immediately, right? And then you, at the very least, destroy that, and of course the endocochlear before, potential. This is the Finley et al. Article again, that WashU article from 2007, really or 2008, that really kind of correlates the number of electrode contacts into scala vestibuli with performance decrements, right? So on the left-hand side, you'd have on the y-axis the CNC word recognition scores. So folks that are up here, statistically speaking, have a lot of electrode contacts, again, in scala tympani as opposed to scala vestibuli. And you see down here on the bottom, all these poor performers, they were primarily inserted in scala vestibuli. Becomes very apparent here by the non-bold, circles here. So, so why does this really matter, right? I mean, back then, again, and that's over 20 years ago, first described early in 1999, there was clinical evidence of putting an electrode into the inner ear and and hearing can be preserved. Actually, even in 1997, there was an article from Miami. I know some folks are here from the University of Miami that showed unintentional hearing preservation, really in up to 50% of patients who received the cochlear implant. Back then, we really didn't think that was possible. So really that Miami article then set up kind of folks who really tried to preserve hearing. And again, first articles came out in 1999 and thereafter. So we had clinical evidence really of being able to preserve hearing successfully despite inserting a multi-channel cochlear implant electrode. Histology, however, showed that we really traumatized the base of the cochlea, and that these scala vestibular insertions were done when we just used this blind cochleostomy approach, right? So certain ideas came up of instead of using this blind cochleostomy approach for opening the inner ear, to use a surgical landmark, right? Again, as opposed to this blind promontory cochleostomy. Here you see this is a Medel electrode, right? You see the drilling cone where we try to access the inner ear here, and you see how the spiral ligament through the electrode insertion is really avulsed, right? You can definitely tell that this is probably not an atraumatic insertion, or most definitely not. And how do we deal with that? How do we as surgeons get a more consistent kind of approach to the inner ear? And nowadays, over 20 years later, you're on this call very familiar with what needs to be done to avoid that, right? So this talk is really the journey basically to where we're at now, right? If you want. So again, what we needed was surgical access, right? That consistently provides non-traumatic scale tympani access, right? We want this as shown before, or this here with a metal electrode, right? We need atraumatic electrode or less traumatic electrodes. Also electrodes that remain in scala tympani rather than to translocate, right? Where we insert it into scala tympani, but then all of a sudden they end up in scala vestibuli. And we need to limit our insertion depth. And we had very limited, and still have, very limited tactile feedback, right? So we didn't really know if we insert an electrode. You as a surgeon really cannot sense that, if you're getting any trauma, right? But stepping back a little bit, let's look at the anatomy in that area, right? Obviously, the structure that interests us is the round window itself, right? It was described a long time ago, right, as a second, basically, tympanic membrane, essentially, right? It also has a conical shape. So think of the round window as a second tympanic membrane, right? It's not a flat structure. Some people call it a Pringle chip, right? It's actually very similar to the eardrum, right? So it's a second window, has a conical shape. It's not flat. And if you look at this Anson and Donaldson book that many of you may have heard about of ear anatomy, real temporal bone anatomy, right? But Anson and Bast really described the embryologic development, right? If you don't have the Anson and Donaldson, it's a fabulous book for inner anatomy. And then it gives the round window approach was first described for a cochlear implant, right? And why not? Because scale of tympani terminates at the round window, right? And if you look at the history of cochlear implantation, it was described, by Dr. House, right? Initially in the 60s even, but then articles to specifically address it were published in the 70s here with Michelson, House and Urban, and then Clark in Australia, and Michelson and Schindler in the 80s, right? However, as this was all for single channel electrodes, or for early first generation cochlear implants. There's a guy in Germany, his name was Banfai. He discussed really difficult with the round window approach, because at that point, folks talked about multi-channel cochlear implant electrodes. And with these multi-channel electrodes, the round window, as you can see in a little bit here, just has a very awkward angle. And folks were worried that if we use the round window, we won't get the electrode all the way deep enough into the inner ear. And again, the Europeans like to use a lot of endural approaches, right? To use an endural approach for a cochlear implant, which obviously we wouldn't do it at this time, but they felt that the electrode, especially with an endural approach, if you look at the geometry, really was ultimately was deflected by the modulus towards the outer wall. So they wanted to get that straight shot for these early generation, very rigid, cochlear implant, multi-channel cochlear implant arrays, right? And then again, the rigid and straight arrangements to scale tympani, right? This is a article from Briggs, that had a nice figure here. And you can see the round window here with this conical shape. And the posterior part of the round window, you see how close this, and I have some pictures from my own lab where you can see the posterior part of the round window almost fused, not almost, but I have some cases where it's in fact fused with the very basal portion of the osteospiral lamina, right? So again, if you use the round window, these rigid electrodes were bouncing off. Folks didn't feel like you can get them far enough in, and the depth of insertion was considered to be an issue, right? And again, you got early resistance, right? And the two solutions that folks came up with is to drill the bony hook. Unfortunately, in this paper, this is called the Christoph Fenestra in this article. That's not the crista fenestra, right? The crista fenestra is a little bony crest. It's also called the crista semilunaris. That's behind the round window, really in the inferior portion of the round window. But it's just behind it. It's just a tiny little bony crest. This area that's dark here, it's considered the bony hook of the cochlea, right? For those of you who have experience with animal, especially rodent experiments, you can see that the hook region can be 90 degrees oftentimes, right, in non-humans. So then the other option was, again, to drill the bony hook or to drill a cochleostomy, right? To come from a little higher up and just get a straight shot into the cochlea, right? Although I would argue you don't really know what part of the cochlea. And then again, the conical shape that I mentioned here, you can see the round window and how it is fused with the very basal portion of the osteospiral lamina, right? This will be rhizomous membrane. It's a little artifact that it's wiggled like this, and at the very basal part of the organ of Corti, right? And again, one of the problems in humans is that the overhang is often hidden, right? The round window is hidden by an overhang, I should say. And that you can have, if you really go posterior in the round window, the round window itself, again, can be fused with the osteospiral lamina, right? And if the trajectory that we usually look at the round window is, of course, from the facial recess, right? And the anterior margin, right, is in this vertical plane. Sometimes we open the recess, right, and the round window looks straight at us. And the posterior portion of the round window is hard to tell oftentimes because it can be in a horizontal plane. So the round window even is often actually bigger than you think it is, right? If you drill a recess far enough, big enough, and you move the microscope, looking from inferior up, and you can see that part of the round window as well, right? And that's usually the distance of the round window with the osteospiral lamina, but again, it can be as little as 0, right, as shown here. And the hook region, as mentioned earlier, in that illustration, narrows the very basal part of the scala tympani, right? The outer wall of the scala tympani is visible only after bone removal of the round window. Right? And this is the anatomy, right? We all know these issues. There can be a lot of soft tissue here. Usually we have to remove that to see the actual membrane of the round window. So you can see the depth of the niche, the width and the diameter vary greatly. That's well documented in pretty kind of ancient literature on the round window. But as we all know, that can be oftentimes a barrier for intertympanic applications. Here's another paper that actually this is taken from the same paper. This also falsely, unfortunately, illustrates this is the crista fenestra as well, the bone, the hook region, right? But the trajectory that you would look at the round window is somewhere here, right? You would look from posterior, this is the facial nerve, right? Oval window niche, and then the osteospiral lamina as it curves around and separates scala vestibuli from tympani, or then scala media, depending on how far lateral you go. And you can see here how posteriorly, right, that's well done in this illustration, I think, how close the round window is to, the beginning of relative vestibular scala vestibuli here, right? And yeah, so bony hook blocks the straight insertion. Do you need to drill it in hearing preservation, right? And again, I mentioned some of these things already. The posterior overhang is much smaller. That the posterior part of the round window is hard to see, just as a summary here. And posterior part of the round window is close to the OSL. So you shouldn't really drill on that area. I said careful drilling. I should just stay away from it. And then, of course, the trajectory, right? Again, for these early cochlear implant days, rigid electrodes, you needed to have a really straight shot into down the lumen of scala tympani, right? I think with a 632 electrodes from Cochlear, it became more and more pertinent to have an idea of how the cochlea rotates, right? You need to angle the electrode accordingly. And again, sometimes the round window can be posterior facing, where you again open the facial recess and you're like, oh, this is easy, right? Sometimes it's superior facing, right? Especially in infants, for example, if you implant 9, 10 months olds, right? The inner ear sits a little differently in the temporal bone, right? So scala vestibuli always takes almost like a superior trajectory in little kids. That usually normalizes or gets a more adult configuration in the first years of life, but can definitely be different. So let's talk about some of the insertion studies. And that's sort of when I was a resident, through a series of lucky kind of circumstances, I sort of took over this insertion lab, right? It was a histology lab. And yeah, I was new to cochlear implantation. I didn't really know anything about it, right? It was new to ear surgery, period, right? My mentors back then told me to drill this cochleostomy, right? This blind cochleostomy on the promontory and just aim for the tip of the nose, right? And the questions back then was I saw, a group from Poland. They're still a very active group, and they used a round window to insert a cochlear implant electrode, and I'm like, wow, that's really bogus. So why would you ever do that, right? But their clinical outcomes were really good. So I'm like, well, I'm new to this. Let's just look into that, right? And those were kind of the questions that I sort of came up with my colleagues, of course, back then. And we wanted to, again, know about where to drill a cochleostomy. Should we even drill a cochleostomy? Should we just use the round window? And if we use the round window, should we just use this round window related cochleostomy that we all know, right? And this was like 2002 and 2003, right? Over 20 years ago. And again, should we use a round window like the Polish group back then, or should we use a cochleostomy? And how deep should we insert an electrode, right? There's a lot of rhetoric from cochlear implant manufacturers that pushes one versus the other idea, right? Are deep insertions really more traumatic or not? Is that just a myth? And should we use rigid versus flexible electrodes, right? So those were kind of the core questions we tried to answer at the time, right? And the issues really with the cochleostomy approach is that there are massive anatomic variations, even not just in the round windows, just the whole area of the promontory, right? And the spiral ligament attachment, right? So if you look here, you see the round window, the inferior portion, that'll be the crista fenestra, actually. You can see here, we show bigger, blown up pictures later. But we don't really know where does the spiral ligament attach here. So we can't judge from the outside what's happening inside of the cochlea, right? And we postulated that this direction of the scalar and how the spiral ligament attaches on the lateral wall of the cochlea on the inside is really variable, right? And really how the cochlea curls, right? And again, these are some of the questions that's somewhat redundant from the slide before, right? And what we want, right, if you look at a blow up here, a high resolution image, is you want the Zimmerel electrode, you want the electrode in scala tympani, not touching, well, touching, but not disrupting anything, right? And Dr. Shraghi's on the call here. He came up with, I think in 2004, Adrian, or somewhere around that, you came up with this grading scale that's still used, that I've used for all my studies. And we'll go over that here in a minute. But it basically grades 0 as no trauma to 4, where you basically fracture the osteospiral lamina, right? That has the dendrites in it, right? So those fractures are really bad. And basically it grades cochlear trauma based on the severity of the injury that we see, right? So this will be a fracture, right? We want to avoid that. And keep in mind, in the osteospiral lamina, that's where the little nerve endings are that really, we don't really know exactly where a cochlear implant stimulates the nerve. It's probably at the nodal ranvier, right? Within the Rosenthal's canals. But of course, if you have dendritic loss here, it would propagate, proximally into the spiral ganglia. Here's some other electrodes. That's basically the Flex 26 electrodes right now, or Flex, the series of Flex electrodes. This was brand new at the time. At the time, Medel only had electrodes that had 24 contacts, so 12 paired contacts. And then I helped with that development of really cutting down on the apical electrodes. So right now, Medel pretty much exclusively uses these Flex electrodes, where the first 5 electrodes contacts are not pairs, but single electrodes, right? And this is an electrode contact, right? And there are 2 wires left, so you can tell this is the 3rd electrode contact, right? So you can basically see where you're at on the electrode, how many, with a Medel device, right? At least how many wires are left in the celastic or sheath, of the electrode in the silicone base, basically where you're at. It's nice here, tectorial membrane. You have a little bit of an artifact with tectorial membrane. Again, these are special histologic methods that allow us to section, embed, and then the resin embedding, and then section, the temporal bone with the electrode in place. So even the platinum iridium that's part of the electrode context doesn't have to be removed. So interesting. I'll go over this graph, but it's interesting to understand this graph based for the next few slides, right? But what we saw basically is that so we used the Draghi scale here on from 0 to 4, 0 being no trauma, and 4 being a fracture of the osteospiral lamina. Number 3 would be a dislocation into scala vestibuli. Number 2 would be a rupture of the basal membrane, and 1 would be a slight elevation of basal membrane. So 1 is probably nothing, is reversible, probably nothing that's really damaging, but 2, 3, and 4 are certainly in increasing severity here, trauma and the inner ear, right? So, and then on the x-axis here, we have insertion depth around the modulus. So number one, what's immediately apparent is that most electrodes were inserted about 360 degrees. And we used the Zhu et al., way to measure that, based on X-rays. So we implanted the electrode, X-rayed it, and then did the histology, right? So that was kind of the process. And we saw most electrodes were just fine, 360. There was one electrode that was really inserted quite far, despite the fact that it's a flex EIS electrode, so 26 millimeter long electrode. And so that must have been a small cochlea. At the time, it wasn't really that known that, we had such a broad variation of cochlea size that we're dealing with, right? But you also see some of these folks had really big cochleas, right? So if you have a big cochlea, it's pretty clear you're probably not very traumatic. But what we saw too is that several of these electrodes, right? I think these are 10 here. So 1, 2, 3, 4, 4 of the 10 electrodes had severe trauma and fractures right as we entered the cochlea, right? And again, that was based on the notion that we just used this blind cochleostomy in the temporal bone lab, right? So that's so we were surprised. We're like, well, we're just not very good at opening the cochlea, right? So and then that gave rise to more studies, right? But certainly, as I was early in my career, right, it was something, we felt like we needed to look into. These are some standard electrodes, and I will say here that, in a temporal bone, even if it's fresh harvested and not frozen, not thawed, that you can't really insert electrodes as far. We used like Helon, hyaluronic acid, to lubricate it up, but even these rigid electrodes, right? And guess those are bigger electrodes. You can see a lot of insertion trauma here right around opening the cochlea. And you can see some of these too, and we got a lot of friction. You basically buckle the electrode into these structures right as the basal turn starts to turn up and convert into the middle turn, right? So that was kind of an interesting finding too. Here's some histology pictures from that lab. Again, this is the one I showed earlier where you can see a drilling cone, right? And it fractures everything. It may stay in scala tympani, right? But you've certainly created a lot of trauma here right at the entry of the cochlea, right? Here's another one. This is a nice one, right? Where we drilled really inferior, right? And this is a contour advance electrode, and we're able to avoid, the spiral ligament altogether, right? So this is probably a pretty nice insertion. And then we inserted electrodes through the round window like the Polish group did, clinically. And we're like, wow, it's better, right? And again, I was pretty inexperienced at that time. We had one where we inserted, and then that must have been a small cochlea because that's really far inserted. And then as we pushed on the electrode, right, you get more and more trauma. So you get an elevation here, and then subsequently you get a dislocation into scala vestibuli, right? And it's interesting that it happens. Usually it happens sooner, right? If it starts elevating here at what's that, probably 260 degrees, and then starts to translocate it here at 360, right? So, and again, these are all Medel electrodes for this particular study, right? So we saw lower chance because the other one had 4 out of 10, right? This basically had really 1 out of 8, maybe 2, but this was a primary scala vestibular insertion eventually, right? But we saw less, basal trauma. Really, I would actually argue for all of us, right? If we do it now, we probably avoid that altogether, right? Or have very little of that, knowing what we know now. And then round window insertion, right here you see the round window, right? And here you see the osteospiral lamina and spiral ligament, right? You see the round window niche here, how the electrode enters the scala tympani. Here's another one where you can see remnants of the stapes, right? And the electrode here in the very basal part of the cochlea, right? This will be the vestibule, obviously, right? So yeah, pretty nice. It's a little disorienting to look at some of these kind of random cuts of the temporal bone. And then really what we wanted to know, right, and these were a series of studies, really two studies that came out in 2000, I think 7, where we really looked at where to drill. So if you used a round window and you want to just use the round window as a landmark, where do you start to drill the cochleostomy? Do you drill it inferior to the round window, right? You go straight inferior to it, or do you go anterior inferior? Right. So if you look at this, I can show you all the data here in a minute, but this will be an example. So we put the intra pictures, right? So through the facial recess, drill the round window niche, and then the cochleostomy, and then here the same thing here with again inferior cochleostomies versus anterior inferior cochleostomy, and basically compare these images with histology, right? Here's another illustration with the two cochleostomy sites. And we took 28 pictures here, 28 temporal bones, and we actually compared the site of the cochleostomy, right, all around when they're related, with their histology. And what we found that it's just a blow up, right? Inferior, anterior, inferior cochleostomy. So the picture I showed already twice happens to be an anterior, inferior cochleostomy. So the bottom line is don't do that, because if you drill anterior, you just don't know where that spiral ligament insertion point lateral in the scala tympani is, right? So first of all, even if you use an anterior inferior cochleostomy, right? In all cases, we had 100% scala tympani implantations, right? That was thought to be one of the issues back then, that some of these electrodes will end up in scala vestibuli, right? So again, for both, you're still going to get them into scala tympani, even if you use a little anterior and inferior. Inferior cochleostomies, however, had basal trauma, right, to the spiral ligament or osteospiral lamina in 0 out of 27 specimens, right? So, and we did more of these inferior cochleostomies because that kind of concept of not going anterior was kind of new at the time, right? Now we sort of again learn about it, but we really wanted to get a high number of inferior cochleostomies to really explore that. Anterior inferior, however, we only did 7 of those, but we had basal trauma to the spiral ligament at least, or then other structures such as the OSL in 2 out of 7 specimens. So in all of these specimens, we at least had an avulsion of the spiral ligament, and in some of it, again, greater degrees of trauma to the osteospiral lamina. So again, inferior cochlear, use the round window, stay inferior. We'll sum up kind of the clinical data here soon. And then the role of insertion depth, right? A very controversial topic. I get it. The hypothesis is really the deeper the insertion, the greater the trauma, thus the likelihood is to preserve hearing. However, the other hypothesis that the more you insert, the longer the electrode you have, right, the better the electric stimulation, at least the coverage, of the cochlea, right? So at least we felt like most of us these days feel like we need to cover at least one full turn of the cochlea. But again, there's some marketing out that says we need to actually be inserting electrodes longer than that, right? And you can see here, this is a standard electrode, a Medel standard electrode. You have 2 electrode contacts, right? So it's not one of those flex electrodes that only has 1. But if you just look at the dimensions of the scala tympani here, again, basal turn, middle turn, and that you get into the like late middle turn here, early, apex, cochlea apex. You see how small scala tympani becomes. And really what's really small is the height of scala tympani, right? So it's really, really kind of small. And you have an electrode that's bigger than the hole you got to try to put in. So in my mind, you can definitely see that this is going to cause trauma, right? This is a flex electrode, right? Where you can see even if you insert the electrode basally, right? Since you encounter some insertion forces here, the basal part of the electrode wants to buckle, right? You can see this here, right? So you insert, you actually, when you push on the electrode as a surgeon behind, on the outside of the round window cochleostomy, you just move the electrode here. You don't actually move the tip of the electrode, right? Just basal buckling, and here you see a fracture, right? But this is probably a 720-degree insertion or so, right? This is the last electrode contact. There's no wire left, right? You can see that we probably have 2 full turns here, right? We can see 4 electrodes. So nice insertion. You can also see that the electrode here at 360 or a little beyond 360 wants to push up into, the scala tympani. But look at the geometry of the outer wall of the cochlea, right? If you look at that, you're like, well, yeah, of course, it wants to go higher. It wants to go towards scala vestibuli, right? And here, half a turn more, you can see that it really pushes up the basal membrane here, right? So, and what we saw in these flex soft electrodes, this is basically a 31.5 millimeter electrodes that you push. You see this basal buckling here, right? As you push in, right? And then you can see insertions, some of them really high, great degrees of insertion, but, certainly more and more trauma, right? So the longer you insert electrodes, just statistically speaking, you may get away with a cochlea that's really large, right? That you really get away with like even a 34 millimeter electrodes now, but it seems unlikely, right? So it's just so insertion depth, does seem to matter negatively, really, for insertion trauma. And then another question we had is flexible electrodes versus rigid electrodes. So the paramodal electrodes, right? They're more rigid because they're preformed, right? So back then, the contour array, for example, versus what a free-fitting electrode. Free-fitting would be, a Medel electrode or a 622 or something like that, right? And we really wanted to know how that kind of works out, right? And we found that, sorry, I don't have a histology graph here, but we certainly found that a rigid electrode cause a lot more trauma, needs kind of this straight shot into scala tympani, still does a little bit more, even the 632, than, kind of a free-fitting electrodes. For free-fitting electrodes, oftentimes we just insert them through the round window. So really, the summary of the temporal bone studies is really that cochlear opening matters, right? Just blind promontory cochleostomy causes basal trauma. Sometimes, at least back then, and keep in mind that's like 20 years old, but sometimes scalovestibular insertions. Inferior cochleostomies, were used a round window as a landmark, are non-traumatic, right? You can do that. Again, if you extend the cochleostomy, if you extend the round window, do it inferiorly. Superior to round window will lead to extensive trauma. There's no question, right? Including scalovestibular insertions, right? And anterior, you may get away with it, but with meaning being a scalovestibular insertion, but certainly you will avulse the spiral ligament from the inner wall of the cochlea there, right? And again, electrode insertion, more trauma with deep implantations. Again, some manufacturers have some rhetoric around that I don't agree with based on histology. You may get away with it with a really big cochlea, but I wouldn't count on that, right? Flexible arrays, really, that are not very rigid, so super soft arrays, one turn, pretty much no trauma, right? I mean, as long as you know your cochlea opening, unless the cochlea has some size variations that are really out there, really wouldn't expect any trauma. So one turn, maybe 400 degrees, you can pretty safely insert an electrode without trauma. And then rigid and pre-shaped arrays, you need to avoid that hook region, right? That hook region, again, falsely called the crista fenestra, it's not correct, is really important. And overall, really, there's a good correlation with anatomical data. So the histologic data just makes sense if you look at you put it in context, of the anatomic data that I showed early on. So then the clinical algorithm, right, is just a conclusion of this. It's really large facial recess, right? I mean, drill or large facial recess. We really want to see the chorda. I mean, I'm not a huge fan of moving the chorda, but I'm a huge fan of having it for a large facial recess, right? Really remove the anterior part of the round window overhang. Be very nimble about the posterior part of the round window overhang, right? So really be careful towards the premolar process, right? Assess the position of the round window, look at it. If it really just looks at you, right, from the facial recess, just implant a special flexible array, just go through a round window membrane, right? Pre-shaped array, sometimes you even get away with that, that you can do a separate cochleostomy, separate meaning a round window related cochleostomy, right? Anatomically related, and again, you want to be inferior to the round window, not interior, right? And then if you have an inferiorly facing round window, one that you look at through the facial recess in a more tangential fashion, right? Use a flexible array. If you use a flexible array, stay inferior, do a round window related inferior cochleostomy, or sometimes even use the round window still, right? Just really, as long as you have a big enough facial recess, you can change your microscope angle and you can do this, right? Pre-shaped array, use a cochleostomy, right? I mean, I would say if the round window anatomy, the orientation is really unfavorable, just open it inferiorly and drill this cochleostomy. I shouldn't say separate cochleostomy, a round window related cochleostomy. So really, in summary, insertion trauma is, again, potential avoidable. Need to know the anatomy. Temporal bone lab is critical. Certainly, it helped me early in my career. Clinical algorithms should follow the evidence, right? Use the round window as an anatomic landmark, right? Use flexible electrodes, like in limited insertion depth, and you'll be able to avoid trauma, I think, altogether in most cases. I think that's all I had, really.
Awesome. Well, thank you so much.
No problem. No problem. Yeah, happy to take questions, obviously, but yeah.
Well, I'll start by opening it up to questions if anyone has any from the audience.